Um, our next speaker is Bjørn Hofmann, who is a professor of medical ethics at the University of Oslo and specializes in the field of medicalization and or diagnosis. So Bjørn, I hope your link works well.
Hello, my name is Bjørn Hofmann. I'm a professor at the Center for Medical Ethics at the University of Oslo, but also at the Norwegian University of Science and Technology at Gjøvik. Welcome to this presentation on making people sick in the pursuit of health. Please allow me to start with a quote from Aldous Huxley, who said that medical science has made such tremendous progress that there's hardly a healthy human left. I think that's very much expressing the core concern of this presentation. In this presentation, I will present 3 ways that we're making people sick in the pursuit of health. The first is doing too much, the second is doing too mild, and the third is doing too early. The first we can do in 3 different ways. First, we can find biomarkers and other types of indicators that do not matter to people's health. We can also make ordinary life conditions treated as diseases, like grief, for instance, or we can also make deviant human behavior and diagnose that as disease. In the case of too mild conditions, we can set the cutoff limits at such a low level that it doesn't matter to people's health. And the third category, diagnosing too early, is when we diagnose conditions that are not relevant to people's health, i.e. that we detect conditions that they die with and not from. Looking at the first type, diagnosing too many phenomena or making too many things disease. In that case, we identify and detect new phenomena such as biomarkers, precursors, risk factors, or predictors. Often we can call them indicators of various kinds. And we give them names and we diagnose them. And oftentimes we handle them as diseases. Looking at the first type of excessive diagnosing, we can see that we may diagnose too many phenomena, i.e. we make too many things disease. For instance, if we look at a certain person, we can see that we can find a series of indicators or biomarkers or precursors of disease, but they will not characterize anything that is experienced by the person, him or herself. So there's a weak relationship between the biomarker and what is experienced by the person, him or herself. We can also diagnose ordinary life experiences and make them disease. One example of this is grief, which has been classified as disease in some classification systems. This type of too much diagnosing is oftentimes called medicalization. Additionally, we may also diagnose too much when we make human behavior, deviant human behavior, a disease. ADHD may be one example of this. The challenges with these types of too much diagnosing is that we may end up with a wrong treatment. We may also come to harm from unnecessary or such wrong treatment. Even more, we may divert from more efficient measures to help people with their challenges. And also it may digress responsibility, and of course also generate anxiety, stigma and discrimination. These types of too much diagnosis have had many names, as we've seen: medicalization, but also maldetection and overdetection. The core type of expansion here is including new phenomena, and the class of expansion is an ontological expansion. The second main type of diagnosing excessively is diagnosing too mild cases. When we lower the detection thresholds, we can include milder cases in the definition of the disease. However, these mild cases may not bother the person at all. Gestational diabetes and chronic kidney disease may serve as only two examples of this. If you look at a specific person, we may detect by various means specific conditions, but these conditions may be so mild that they do not bother the person. They do not call attention or come to the person's experience either as pain, suffering, or dysfunction. We think that we do something good for the person, but what happens is oftentimes that when detecting milder cases and treating milder cases, we think that we have a successful outcome, but the point is that we only have come to treat milder cases of this specific condition. One of the challenges with diagnosing too mild cases is that we may end up with unnecessary treatment and also potential harms from diagnostics and following from such unnecessary treatment. Sometimes diagnosing too mild cases has been called misclassification or overdefinition. It's a type of expansion of disease by degrees, and it may also be called normative or conceptual expansion because we lower the threshold or the limits. So we lower the norms, or we change the norms for specifying a specific diagnosis of disease. The third type of excessive diagnosing is diagnosing too early. We may be diagnosing abnormalities that are not going to cause any harm by disease in terms of pain, dysfunction, or suffering. So these are conditions that people die with and not from. And there are many examples of precursors of disease that do not develop into disease. Ductal carcinoma in situ and various types of polyps, about two examples of this. Certainly, early detection can be crucial and important. For instance, if what we detect early can be treated so that what it otherwise would have caused would not occur. By that we could prevent disease, of course. But if we detect something so early that it wouldn't have developed into something or anything that the person would have experienced and the person would die from other causes, then we would not benefit the patient by detecting these things, i.e. we would detect things too early. Diagnosing too early is oftentimes called overdiagnosis, and it may lead to overtreatment and also having potential harms from the diagnostic process, but also side effects from the overtreatment, i.e. the unnecessary treatment. This expansion of diagnosis is a temporal expansion, and it may be called an epistemic temporal. It is temporal because we try to or are not able to foresee what will happen in the future, i.e. whether the person will become ill or not. And it's epistemic because of our lack of knowledge of what will happen to the patient if left untreated. There's a specific type of uncertainty involved here, and that's progression uncertainty, because we do not know how and whether what we find will progress, and whether it will progress into something that is relevant for the patient's life, i.e. whether the patient will experience symptoms, pain, dysfunction, or suffering. So I have tried to identify 3 ways that we're making people sick in the pursuit of health. We can diagnose too much, too mild, and too early. This table provides an overview of the 3 types of excessive diagnostics where we can come to harm patients more than we benefit them. Hold and put the presentation on pause so that you can look closer at all the elements. It is also important to recognize that the 3 types of excessive diagnosis, they partly overlap. So you can have both too much, too mild, and too early at the same time. In addition, we also have other types of diagnostic errors, and together you may say that these make up too much diagnosis. In addition to the 3 types of excessive diagnosis, too much, too mild, and too early, and also other diagnostic errors, it's important to acknowledge that we have a 5th type of unwarranted diagnostics, i.e. that is unnecessary tests, where we make low value diagnostics, and that can be defined as testing that does not change the patient's pathway or improve the patient's health. At the core of what we've been talking about is a basic challenge, and that is that it's harder to make a person who feels well to feel better than to make the person feel worse. And the challenge can be illustrated in the following manner. If you look at the person's life with a fairly good quality of life, and then the person becomes diseased, and at the end the person dies. If during the healthy period we try to improve the health of the patient or the person, we do have to put in a lot of efforts in order to increase the quality of life. However, the risks may be substantial and compared to the benefits. However, if we try to amend a person who has reduced quality of life and to try to help him or her, we may have a similarly substantial risk, but the potential benefit may be greater. It's also important to acknowledge that while the benefits will come in the future, the risk will come at the present time. So there's a displacement of risks and benefits, and it's important to take this into account. If you're interested in reading more about this, here are some presentations or some publications where you can gain more information about this, and especially different ways that we tend to expand the concept of disease. And disease expansion is, of course, important if it can help us provide better care for patients, but oftentimes the opposite happens. So we need to be aware of unwarranted expansion of disease. So thank you for your attention.